A very good evening to all of you. I once again welcome all of you to the Oculoplasty Essentials course by Dr. Subramaniam sir. And this is the fourth in the series of 15 lectures sir is going to deliver. So in this particular class, sir will be covering about the principles of lid reconstruction. And one more specialty that we have in today's episode is we also have a case presentation from a second year REH student, Dr. Gautami, who will be presenting a case after Sir's class, and the case is on congenital ptosis. And we also have distinguished faculty from REH Vizag, Superintendent Meenakshi Madam, Jyotirmayi Madam, and also Prabhakar Sastri sir, who have joined online through the faculty link. I also see some students that have joined through the faculty link. I request all the others to keep their voice on mute so that there is no disturbance to the class. Once the class is over, you can feel free to ask any questions or doubts to Subramaniam sir. Followed by that, we'll have the case presentation from Dr. Gautami. I welcome you all once again, and I again thank Subramaniam sir once again for taking his valuable time out and taking this Oculoplasty Essential course. Delivering a 15 lecture course is by no means a small feat. Sir has dedicated a lot of time and effort into that. Hope all of you are benefited through this educational endeavor from APOS. I request Subramaniam sir to take over from here.
Thank you, Madhu. And welcome to all the people who are joining this webinar. So I'm speaking on lid reconstruction techniques only, which are a bit difficult to understand for postgraduates. I'm not going through the details of various tumors and the clinical features and others, which can be easily read and understood. Okay. As I said, always, it is not complete and you have to read. Now let's start with a little bit of the anatomy. Let's remind what we have already studied in the first class. The lid can be split into two layers. The anterior lamella, comprising of the skin, subcutaneous tissue, and orbicularis oculi, and the posterior lamella, comprising of the tarsus and the conjunctiva near the margin, and above that, the levator palpebrae superioris, Mueller's muscle, and conjunctiva in the upper lid, and inferior retractors, Mueller's muscle, and conjunctiva in the lower lid. Right. Both join at what's called gray line, which is an anatomical landmark for various surgical procedures. Or if you want to split the anterior lamella, that's a good surgical mark. Let's look at the common lid tumors. The benign or the nevus, capillary hemangiomas, and squamous papillomas, apart from viral warts, and various cysts from glands of mole and disease and other things. And whereas the malignant, though the textbooks say that basal cell carcinoma is the most common malignant tumor, nearly up to 90%, in India, the most common tumor is meibomian carcinoma or sebaceous gland carcinoma. Because of the pigment, we are protected from BCC, and basal cell carcinoma is the second most common lid malignancy among Indians, followed by squamous cell carcinoma and rarely melanoma. Here are the few benign tumors. Here you can see in the margin there is a pigmented growth. This is the nevus. Of course, he has the nevus of the conjunctiva. This is called the kiss nevus or kissing nevus, which involves where the nevus has found before the lids get separated, so that almost equal amounts of the lid margins are involved in a case of his nevus. Here is a case of capillary hemangioma, which is fairly common, which may be involving as a just small tumor over the lid, or maybe rarely involving the entire half of the face like this. Here is a small lid tumor which is looks like attached to the stuck up to the lid. It's a benign tumor, and here you can see a cyst hydradoma of the lid, hydradenoma of the lid. Similarly, conjunctival inclusion cysts are also fairly common. How do you manage a capillary hemangioma? If the capillary hemangioma is small and is not causing obstruction to the pupil, instead of leave, the old teaching was leave it like that. But as you are aware, this can cause astigmatism and can cause amblyopia. So a better way of treating it is either with timolol topical application or with the help of a pediatrician, you can put the child on propranolol. If the tumor is big enough and obstructing the pupil, as in this case, to hasten the absorption, we can give intralesional triamcinolone, about 10 to 20 milligrams, depending on the size of the tumor, intralesional and perilesional triamcinolone, so that it heals, it absorbs very fast, and the pupil gets uncovered, and the chances of developing of amblyopia are reduced, not totally zero. Here, this child has an orbital component also. So this is 2 weeks after giving the intralesional and perilesional triamcinolone to hasten the absorption of the or resorption of the hemangioma, so that you can see that the pupil becomes uncovered. And then the child was put on oral propranolol at a dose of 2 milligrams per kg body weight by the pediatrician. This is 2 months down the road. At about 6 months, about 1 year, and at the age of about 4 years, by which time he developed a refractive error, a convergent squint, and had hypermetropia. We treated it, and then we did a squint surgery, and the eyes became straight, but the visual acuity was 6:12. A bit of amblyopia was there in that case. When to suspect malignancy is the most important thing, because you have to, the treatment strategies depend whether the tumor is benign or whether the tumor is malignant. And you cannot afford to miss a malignancy. If the surface is irregular, if there is an ulceration, loss of cilia, because as the tumor infiltrates the hair follicles, there will be loss of cilia. There could be new blood vessels and rounding of posterior eyelid margin, and a suspected blepharitis which is not responding to medical treatment for 3 to 4 weeks. You have to take a biopsy to rule out a pagetoid spread of squamous gland carcinoma or squamous cell carcinoma or maybe cell carcinoma. Sebaceous gland carcinoma is the most common and most aggressive lid malignancy. Is the most common in India. It's more common in females and in upper lid, because upper lid has more number of meibomian glands than the lower lid. It is painless, slowly enlarging in size, and its differential diagnosis is chalazion in the early stages. I have seen patients, nearly 30% to 40% give history of previous surgery for a chalazion, incision curettage, before they come to us with a big tumor, right? So whenever you think that, suspect that the lesion is chalazion, please make it a rule to avert the lid in every case of suspected chalazion. Chalazion surface is smooth, whereas in sebaceous gland carcinoma, it is irregular. Sebaceous gland carcinoma is the only lid malignancy that can be fatal. 5 to 10% can be fatal if not properly treated. A non-responding blepharitis, as I said, can be sebaceous gland carcinoma. It is usually misdiagnosed as chalazion. Immunosuppression, HPV virus, human papillomavirus, or risk factors. Basal cell carcinoma is the second most common in India, but is most common type of lid malignancy among white races. It could be associated with Muir-Torre syndrome, that is BCC plus keratoacanthoma plus colorectal cancer. It is a slow-growing tumor. It is present in sun-exposed areas. Lower lid is the most common site, followed by medial canthus and then upper lid. When is surgery deferred and you are not able to do surgery, because most of the lid malignancies, the first option is surgery. But there are conditions where surgery cannot be done, either because of the size of the tumor or because of the general condition of the patient. In those conditions, you have to think of alternatives like radiotherapy, Vismodegib, 150 mg per day for several months for chemo reduction, or imiquimod, 5% cream, once a day for 5 days a week for 8 to 6 weeks. To be honest with you, I don't have personal experience with Vismodegib or imiquimod. Squamous cell carcinoma, the risk factors are HPV virus infection, human papillomavirus infection, HIV, immunosuppression, including those who are receiving immunosuppressive agents like steroids for long periods following organ transplantation, UV exposure. Xeroderma pigmentosum is a very important cause of squamous cell carcinoma occurring in young age group and children. Actinic keratosis is pre-malignant, and cigarette smoking. What are the common indications for reconstruction of the eyelid? Most common is lid tumors after excision of the lid tumors, or it could be congenital coloboma, or a coloboma following trauma with tissue loss. These can happen, especially more and more common nowadays, because of the increase in the violent trauma due to road traffic accidents. Lid tumors. What's the aim? The aim is excision of entire tumor. When the entire tumor is excised, then you have to reconstruct a functional and aesthetic lid with adequate tarsal support. So this is the thing. So number one is excision of entire tumor. Number two, reconstruction of a lid that is aesthetic, good looking, functional, and has adequate tarsal support. So what is adequate tarsal support? A tarsus 4 millimeters in height and half the length of the eyelid is adequate to support the lid. As you are aware, the support to the human's body is given by the skeletal system, bones. Similarly, the support to the eyelids is given by the tarsus. So you have to leave adequate tarsus to support the lid to have an adequate function. Now coming to the excision can be anterior lamellar when the tumor is involving the anterior lamellar skin only, or it could be a full thickness excision. When we are doing excisions, since we would like to excise the entire tumor without leaving a single malignant cell, as per the textbooks, the three important things that we do is Mohs section. In Mohs section, a trained dermatologist will be available so that this BCC, usually done in BCC, a layers of tissue, malignant tumor with normal tissue are removed, and it is cut into 4 quadrants and marked like superior nasal, superior temporal, inferior nasal, inferior temporal, and sent to the pathologist. So the pathologist immediately studies and tells in which there is a tumor is positive. So let's suppose tumor is positive in the superior temporal slide, whereas that means the margins are involved. Superior nasal, and inferior temporal margins are free. Then what we'll do in the superior temporal region, again take a small bit of it, a slice of the, including the normal skin, and send it again as 4 pieces to the dermatologist, who is the pathologist also. So he will again says, if the tumor is free, all the margins are free, then you are sure that at least histopathologically, the entire tumor has been removed, and then you start the reconstruction. Coming to the frozen section, the entire tumor is removed and it's marked and sent to the pathologist, who does a frozen section and studies and informs you probably within 20 minutes to half an hour whether the tumor is entirely removed or there is no marginal clearance or tumor is present in the margin in which region. So at that region, again, you remove till you get a report that the tumors are margin free. Then you can reconstruct it at the same sitting. Coming to the wide excision, most of the times the tumor has a microscopic extension varying 2 to 7 millimeters from the tumor that is visible. So normally what we do is we excise the tumor about 4 millimeters of a free margin. Then you put a suture at one particular place and send that to the pathologist, informing in which area you have put the suture. He will give the report probably in about 3 days, whether there is any tumor is totally removed or whether the margins are free or involved. So when you do a wide excision, there are 2 options. Number 1, do the reconstruction immediately. If there is, the report is tumor is still involving a margin, you have to carefully follow the patient or immediately take him to the side next week and take a slice and send it. The other option is, after you excise the tumor, put a BCC so that the cornea is clear and then keep it, and once you get the report, then you do the reconstruction. So the reconstruction could be done in 2 stages when you are doing wide excision, whereas if the Mohs section and frozen section are available, you can do very comfortably, very confidently in single sitting. In abroad, I have seen the general ophthalmologist does the wide excision. In a way that is good, because if the same person is doing the wide excision plus reconstruction, occasionally who may be biased to do a little under or a smaller excision rather than total wide excision because of the problems he may face eventually in the reconstruction. Whereas if it is done by general ophthalmologist, he is not bothered about the difficulties of reconstruction. So he does a good job of wide excision and the reconstruction. For the reconstruction, the patient will be sent to the oculoplasty surgeon. So they plan such a way that after excision, within 3 days, the patient will be sent for reconstruction along with the histopathology report. There's another way of doing the things. Coming to the anterior lamellar excisions, it's when the tumor is involving only the anterior lamellae, like a basal cell carcinoma or benign tumors from the skin, including neurofibromas. We'll do an anterior lamellar excision tumor involving the anterior lamella and do a reconstruction. So for the reconstruction, depending on the size of the tumor, it could be either a full thickness graft or a partial thickness skin graft. If the lesion is small and the area of coloboma is smaller than 15 millimeters by 10 millimeters, you can use the excess upper lid skin as the donor, because as we said already, as we know, the upper lid skin, the lid skin is the thinnest skin in the body. So the best matching skin for a lid graft is upper lid skin. Same opposite or other eye. If it is larger, we can go for full thickness skin grafts, post-auricular, pre-auricular, or supraclavicular. If it is even much bigger, you may go for full thickness, partial thickness grafts from the inner aspect of upper arm or inner aspect of thigh. Occasionally, people use the forehead flaps, but the only problem with forehead flaps is that it gives a big scar. That's number one. Number two, the skin is too thick, so it doesn't merge very well with the normal lid skin. So I prefer to avoid it as far as possible. Coming to the full thickness grafts, so the full thickness lid excision is done when the tumor is involving the posterior lamella or anterior lamellar tumors within 3 millimeters of the lid margin. Why within 3 millimeters of the lid margin? As I said, for the wide excision, we are taking 4 millimeters, thinking that the tumor has already spread up to 3 millimeters or more. So when the tumor is within 3 millimeters, there is very likelihood that there is a microscopic extension of the tumor onto the conjunctiva. And as we are aware, conjunctiva is part of the posterior lamella. In other words, it means that both anterior lamella and microscopically the posterior lamella are also involved, and we have to do a full thickness excision of the lid and then reconstruct. This is a big, you can see a pigmented ulcer with irregular margins and ulceration. And this is a separate small tumor which the patient has since his childhood. So this is a no regional lymphadenopathy. So for every case of lid tumor, you have to palpate the preauricular and submandibular lymph nodes for any spread of the tumor. So here, so what we did is we did an anterior lamellar reconstruction. We have excised the tumor skin and a part of the orbicularis and the muscle. This is the gap. This has been closed with partial thickness cutaneous graft from the inner aspect of the thigh. It's a case, another case of anterior lamellar reconstruction in neurofibroma. So it's a very huge mass involving both the upper lid, lateral canthus, and the lower lid. So it's fairly vascular, it was bleeding heavily. So what we did is partially we have excised each and put a skin graft. So it's 1, 2, and 3 stages. We have removed the mass and the patient was looking great. Another case of neurofibroma involving the upper lid with mechanical ptosis, the anterior amellar tumor has been removed along with the skin, as you can see, and we have put a post-auricular skin graft, and that's how the patient was looking 1 week post-operative down the road, and he was doing very good. Full thickness reconstruction, as I said, whenever we excise the tumor, we usually keep a suture and inform the patient pathologist where I have kept the suture. I'll ask for the diagnosis, and I'll ask for marginal clearance. So whenever you are sending a specimen to the pathologist, you please remember that you have to give the history of the case, clinical picture, and what you want, you have to ask them. That's the diagnosis, not just simply the diagnosis, marginal clearance. And for the orientation, you have to keep a suture. You draw a diagram and give it to the pathologist. Remember that the pathologist is there to help you. If you send the specimen without any details, it's as if you are challenging the pathologist to a diagnosis. And remember that pathologists, you are not examining the pathologist. The pathologist is there to help you to make a correct diagnosis so that you can treat the patient better. He's a part of your team, right? Because I have seen a couple of incidents where nothing has been, no history is given to the pathologist. Lump from abdomen for histopathology diagnosis. Don't please write such type of requisitions to the pathologist. Remember, as I said earlier, that the pathologist is your friend. It's a part of your team who is going to help you to make perfect decision to treat the patient. You are not testing his knowledge. Okay. Coming to the full thickness, the things that you have to do is, you have to do the marginal reconstruction. We'll say how to do the marginal reconstruction. And what is the technique? If the defect is up to 1/3, 25 to 30%, you may be able to approach both. And if you are able to approach both the curtains straight, you can do direct suturing. Otherwise, we can do a canthotomy and cantholysis and mobilize and suture that. If the coloboma size is 1/3 to half, we can do a tensile temporal semicircular flare. So both these techniques, that's canthotomy and cantholysis, or tensile semicircular flare, are the same for upper lid coloboma as well as lower lid coloboma. Up to 50% is the size of the coloboma. Remember that the lid has adequate tarsal support. Because what is adequate tarsal support? We said it is 4 millimeters in height. Lower lid tarsus is 4 millimeters in height. Upper lid tarsus is 8 to 10 millimeters in height. And 50% of the lid length. So when the coloboma is 50% of the length, there is adequate tarsal support, and there is no need to provide extra tarsus. There is no need to do lid sharing procedures. When the coloboma is more than half, then the tarsal that is left in the lid is not enough. Then it requires tarsal support from the other lid or opposite lid, and you have to do lid sharing procedures. So for the tarsal support for the upper lid, we can do cutter beer technique. I do a modified cutter beer technique, not the original one, because I want to provide extra tarsus. And for the lower lid, you can do Hughes procedure or an inverse cutter beard technique. For the total lower lid, we can do a Mustardese cheek rotation flap. For the medial canthus, a glabellar flap, and for the lateral canthus, a zygomatic flap. How to reconstruct the margin? This is very important, especially you will be seeing day in and day out trauma involving the lid margin. So the first suture, this is this one, passes through the gray line. But in some of the Indians who are a bit darkish in color, it may not be possible to identify the gray line. Right. In that situation, so here you can see there's a gray line and the first suture has passed through the gray line. In those conditions where you are not able to identify the gray line, what you can do is, what are easily identifiable are the openings of meibomian glands. So pass your suture through the meibomian gland from one side and come out through the meibomian gland of the opposite side and tie it and cut the ends long, right? This is the central suture. Then pass one suture posterior to it near the lid margin and pass one suture anterior to it to the lid margin, anterior lid margin, and all these ends are cut long. Then suture the tarsus. When the tarsus or the posterior lamella is sutured using 60 vicryl, for all these I use 60 vicryl sutures. Then pass sutures through the skin and orbicularis oculi. Then you tie them, and once you have tied the knot, you pass the long cut-in sutures of the margin and enclose them in the second and third sutures. That means you are making sure that these sutures are kept tight and away from the eyeball so that they do not irritate the lid. Because if there is a spastic entropion, the cuttings can irritate the conjunctiva and cornea, eyeball, and can cause lot of pain and problem, which can worsen the spastic entropion. For these reasons, the cuttings should be long and they should be incorporated in the sutures. I usually do it for the first and second sutures. And the rest of them normal, directed, interrupted sutures with 6-0 vicryl. This is how we do the margin reconstruction. Now we'll go into a little bit of the procedures. So this is a small tumor that is there, which we have excised with a pentagon fashion. And this is the coloboma. This coloboma is about, let's suppose, 20%. It's a young patient. You cannot oppose the leads. Then what we do? We do a canthotomy and cut the canthal tendon, cantholysis. Then it is very easy to mobilize this. Then you can do the margin reconstruction as we have already discussed. And this opening, canthotomy opening, can be closed with interrupted sutures. That is canthotomy and cantholysis, a very, very simple procedure. Tensile semicircular flap. So here the tumor is a little bigger, and so a wide excision has been performed, leaving a coloboma which is nearly 40 to 45% in size. Right. Then what we do is we do a canthotomy cantholysis. For the lower lid, we take the temporal flap with the incision going up. For the upper lid, it goes down like this, lower lid. And then you can mobilize the entire skin orbicularis component and then suture the tarsus and then they repair the margin and anterior lamella and close this with interrupted 6-0 vicryl. This is the squamous cell carcinoma, which was repaired with a Tenzel's semicircular flap, as you see can hear. So in these two conditions, since the patient is left with after excision of the tumor, the patient is left with adequate tarsal support, we are not going for lid sharing procedures. It is a single stage procedure. The patient is able to see clearly. The eye is not occluded and it's quite comfortable for the patient. Here is a small child, golden horse syndrome with a coloboma here. And you can see the golden horse syndrome with preauricular attacks. So the child is about 2 months old. So preauricular attacks that you can see both sides. So I did a lateral canthotomy cantholysis. I'm sorry, a Tenzel's flap. I have done a Tenzel's flap and covered it, and the child was doing good. Whenever we are doing lid repair, lid reconstruction for a coloboma in a congenital coloboma in a small child, in the infant, don't use lid sharing procedures. If you use lid sharing procedures and the lid is closed for 6 to 8 weeks, that's the time when we separate the two lids, the eye can go into amblyopia. So lid sharing procedures are to be avoided in treating or reconstructing coloboma in congenital cases in children who are in the developing age, right? In Hughes procedure, here the tumor is much bigger. More than 2/3 of the lid has been removed. Then what we have to do when the lower lid has been removed, we have to provide extra tarsal support. So we invert the lid, make incision 4 millimeters from the lid margin and bring the tarsus down. To this tarsus that has been brought down, that is from the lower lid, the inferior retractors are mobilized and sutured. And then comes the orbicularis oculi, and it is closed on the other side to the cut ends of the tarsus that is remaining in the lower lid. And so this is a sliding graft. Over that, we will have a cutaneous full thickness graft has been done. So this is Hughes procedure by moving the tarsus from the upper lid to the lower lid, right? After 6 to 8 weeks, we separate the lids. Remember that when I am using two lamella, one for the reconstruction of the posterior lamella and one for the reconstruction of anterior lamella, at least one of it should be having its own blood supply. That means it should be a sliding graft. You cannot have two free grafts. They do not survive. So here is the patient with a big coloboma more than 2/3. So an incision is made 4 millimeters and parallel to the lid margin. The tarsus has been, and vertical cuts are given, and the tarsus has been mobilized downwards along with the LPS and along with the Mullers. And then it has been anchored down, to which the inferior retractors are attached. And then it is attached on either side to the tarsus and the orbicularis oculi. And a free skin graft has been put, right? This is how the patient was 4 weeks after surgery with the lid sharing procedure, the lid being closed, and this is after separating the lids. This is how the patient has been with the reconstructed lid, which is aesthetic and functioning. Cutler-Beard's procedure is for the upper lid, where after you have excised the tumor, leaving a very huge graft, huge coloboma, more than 2/3 in this case. What we do is we identify in original Cutler-Beard's method, what he describes is make a incision 4 millimeters and parallel to the lid margin, then make vertical cuts and mobilize entire skin to conjunctiva to the under this flap. This is called the bucket handle, and then anchor them and suture to the LPS, conjunctiva, and everything is sutured. But this is the original Cutler-Beard technique, but you are not providing tarsal support, right? And after 6 weeks, you separate them. But what I do is a modified Cutler-Beard technique. You can see it's more than 80% of the lid has been excised. lid tumor has been excised, and this is the huge coloboma. So what I do is I do a free tarsal graft from the opposite upper lid, 4 to 5 millimeters in height, and the length is that is as per the coloboma, and that is anchored on either end of the tarsus. Then I mobilize the conjunctiva, which has been sutured to the upper border of the tarsus. Then I identify and mobilize the LPS muscle, as you can see here, which has been anchored to the anterior surface of the tarsus. That means with this, I have reconstructed the posterior lamella with the help of a free tarsal graft from the opposite upper lid with mobilization of the LPS and the conjunctiva with their own blood supply and anchoring them to the tarsus at the upper border and the anterior surface as has to be done. Then we make incision full thickness 4 millimeters from the lid margin. And then, since I have already anterior lamella, from this inferior part, I will separate the anterior lamella, only dissect the anterior lamella, give vertical cuts, and mobilize the anterior lamella under the bucket handle, that's the lid margin, and bring them up and suture them. This is modified cutter beard procedure, which I prefer because we are providing adequate tarsal support, which is not being done in the original procedure. So this is the patient with huge meep cell carcinoma. This is the post-operative after stage 2 when I have separated the upper lid and the lower lid. That's only within the first week after separation. This is 3 months down the road. You can see that the upper lid is thin, is good looking and moving well, and there is no lag of thalamus. It's very aesthetic and functional. If the tumor is very big in the lower lid, entire lower lid has to be removed. What we do is access the entire tumor in the lower lid. Again, lower lid, the posterior lamella has been reconstructed with the help of a tarsal graft from the opposite upper lid. Then we do a cheek rotation flap where the incision goes all the way down in front of the ear downwards and with a curved relaxing incision, and the entire skin flap has been rotated to provide the anterior lamella. This is called mustard-based cheek rotation flap for the total lower lid reconstruction. If the patient has a single eye with vision and the only eye with vision has a tumor which is big, then it is practically very inconvenient for the patient if I do a lid sharing procedure, because the lid will be closed for 6 to 8 weeks and patient becomes blind for the 6 to 8 weeks since he has no vision in the other eye. So this is the only eye with vision. So the tumor has been excised. Then what we will do is, this is more than 70%. From the other, we'll do a tensile semicircular flap so that 50, let's suppose for mathematical, this is 80%, is the coloboma. So I can take about 30% of the lid from the opposite eye, right? And that I can utilize it. And I can do, which I can close with direct closure. And I can apply it for the 30%. And the rest of it is covered with a tensile semicircular flap. So this is the coloboma that has been mobilized on the lateral side with the tensile semicircular flap. And the rest of the coloboma is closed with the full thickness flap that I have taken, graft that I have taken from the other non-seeing eye. That is called composite lid graft. So this is the patient with vivo cell carcinoma of the right upper lid. Left eye is being blind. We did a surgery of composite lid graft. And this is how the patient after surgery recovered nicely and he has a functional lid. Total upper lid reconstruction, my method is a combination of tensils plus hooks plus free cutaneous graft. This is the total upper lid tumor involving that I have totally removed. Then I will do a tensile semicircular flap to mobilize it. And then to the rest of tarsus, since is not provided much, we'll do a flap of tarsus from the lower lid to the upper lid, reverse Hughes procedure, we call it. We mobilize the tarsus to which the LPS and conjunctiva are anchored, and then we give a free cutaneous graft, and after 6 weeks, we separate them. So this is the huge tumor involved the entire lid. The entire lid has been removed in the upper lid, as you can see here. Then we did a tensile semicircular flap where we have reduced it, and then this is the hux that is going down. This is at the end of the surgery after free cutaneous graft. So this is the patient with the entire lid tumor after stage 1, after stage 2, when both the lids are separated, 8 weeks down the road, and that patient with a Meep cell carcinoma involving the entire upper lid after stage 1 and after stage 2, and that patient with the entire upper lid being involved with the tumor with the ulceration Meep cell carcinoma after stage 2 surgery, and that old man with a huge tumor involving the entire lid after stage 2. You can see that the lids are closing well and opening well, and the lid is thin, fine, and aesthetically good looking. So the take-home message is avoid lid sharing methods in infants lest they can cause amblyopia. Lid sharing methods are for colobomas larger than 50% in size because they are not left with adequate tarsus. Tarsus from opposite upper lid is an excellent source for posterior lamellar reconstruction. Thank you all.
Thank you so much, sir. Uh, do we have any questions from the students who have joined from REH or even from the faculty before we go ahead with Dr. Gautami's case presentation?
Sir, there are only messages saying thank you so much, sir. Thank you so much.
Sir, the cases and results are excellent, sir. Really, I'm very much. It's very nice to see the cases, how you have done.
Thank you so much, Amma.
I have not seen some of the. Actually, we used to do that when I think you must be knowing Dr. Viswanarayana. At
Yes,
that
yes,
time, we used to do the
he was interested.
rotational flaps and cuttle beard we have seen.
Yeah.
But this one, the total this the closing, non-closing procedure from other you have taken that patch rotational graft that I have not seen before.
That's
Really, but I'm
my
very
own
lucky to
technique,
see that.
man. That's
Yeah.
my own technique.
Uh, I have not seen in the books also.
No, not in the books. It's my own
Yeah.
technique.
Sir, people like you should write the books because every time I say we see only Western names only, but we have to see our own people.
Sir
I
is in
read
the
in orbits where my heart lies. My heart lies more in the orbits rather than plastics. I have written a book on that. And
yeah.
it's fairly well received.
Wonderful results, sir.
Sir. Sir, shall
So we
we
are
go?
lucky that usually from textbooks we'll see the lectures, but here everything is what you have done. You have shown that is really something great, sir.
Thank you so much. Thanks for the nice words.
If there are no questions, shall we go ahead with the case presentation?
Yes, sir. Yes, sir.
Yes, sir.
Okay. Gautami, Dr. Gautami, are you ready?
Yes, sir. Good evening, sir.
Good evening. Please go ahead.
Good evening, ma'am. Am I audible, sir?
Yeah, audible. Are you sharing?
Yes, sir. Can I start, sir?
Yeah, please go ahead.
Yes. Good evening, sir. Good evening, ma'am. I'm Gautami, second year postgraduate from Regional Eye Hospital, Vishakhapatnam. And under guidance of Dr. Meenakshi, ma'am, I'm going to present the case. This is a case of 23 years female who is a student hailing from Vishakhapatnam. Chief complaints are drooping of right upper eyelid since birth. Coming to present illness, there is drooping of right upper eyelid since birth, which is non-progressive and no diurnal variations, not improving with rest. No history of double vision, no history of difficulty in swallowing or change in voice, no history of swellings on eyelid, and no history of elevation of droopy eyelid while eating, chewing, or jaw movements. No history of diminution of vision, no history of decreased sweating on one side of the face, no history of limb weakness. Coming to past history, birth history is normal. It is full term normal vaginal delivery, institutional delivery. No history of any previous ocular surgeries or ocular trauma, and no history of any allergies. Coming to patient is not in known case of diabetes or hypertension, no history of bronchial asthma or thyroid disease, no history of any other chronic illness, and no history of usage of any drugs. Family history is not significant, and personal history, she takes mixed diet, appetite is normal, and normal bowel and bladder habits. Coming to general examination, patient is moderately built and nourished, conscious, coherent, cooperative, and well oriented. No pallor, icterus, cyanosis, clubbing, and generalized lymphadenopathy or pedal edema. Systemic examination, cardiovascular system, no murmurs are heard. Respiratory system, normal vesicular breath sounds. Central nervous system, no focal neurological deficits, and parabdomen is soft and non-tender. Coming to head posture, there is mild chin lift and the right brow lift is present. Eyes are in orthophoria. Ocular movements are normal in all cardinal directions. Coming to local examination, right eye, visual acuity is 6.9, improving to 6.6. Eyebrows are raised, eyelids, upper eyelid drooping is present and lid crease is absent. Lacrimal apparatus is normal and eyeball is normal in size and position. Right eye conjunctiva is quiet, cornea is clear with intact sensations. Anterior chamber is normal depth and contents. Iris is normal in color and pattern. Pupil is normal in size and reacting to light. Lens status is clear. IOP in right eye is 13 mm of Hg. And right eye fundus is media is clear, optic disc shape, size, color is normal, and margins are distinct. Cup disc ratio is 0.3:1. Vessels are normal, 2:3 arterials to venous ratio, and foveal reflex is present. Coming to left eye, visual acuity is 6.6. Eyebrows are normal, eyelids in normal in position. Lacrimal apparatus is normal, eyeball is normal in size and position. Conjunctiva is quiet. Left eye cornea is clear with intact sensations. Anterior chamber, normal depth and clear contents. Iris is normal in color and pattern. Pupil is normal size, reacting to light. Lens status is clear. And left eye IOP is 14 mm of Hg. Left eye fundus, media is clear. Optic disc is normal with distinct margins. Cup disc ratio is 0.3:1 serial. Vessels are normal and foveal reflex is present. Coming to ptosis, proper examination of right eye. Palpebral figure height is 6 mm and the marginal reflex distance 1 is 0 mm and marginal reflex distance 2 is 6 mm. By Berg's method, levator palpebral superioris function is 4 mm and marginal crease distance crease is absent. Palpebral figure height in primary position, right eye is 5 mm. In up gaze, it is 6 mm and down gaze 6 mm. In left eye, palpebral figure height is 10 mm, MRD1 is 4 mm, MRD2 is 6 mm, LPS function is 15 mm, and marginal crease distance is 8 mm. And in left eye, in primary position, palpebral figure height is 10 mm, in up gaze it is 11 mm, and down gaze 5 mm. With these measurements, I can say that there is severe ptosis of 4 mm in right eye. Visual fields and confrontation test is normal. Bell's phenomenon is good. Marcus and jaw winking phenomenon is absent. No lagophthalmos. And on downward gaze, ptotic lid is higher than the normal lid. Ice pack test is negative. Fatigue test is negative. Shimmer's test, it is normal. In both eyes, it is more than 15 mm. Phenylephrine test is not done as it is a severe ptosis. And Herring's test is negative. My summary is a case of 23-year-old female with the right upper eyelid drooping since birth, with a compensated head posture with severe ptosis and absent lid crease and poor LPS function with lid lag. My provisional diagnosis is it's a case of right simple congenital severe ptosis with good Bell's phenomenon and poor LPS function. Left eye is normal.
Did you test for herrings in this case?
Sir, as there is increased innervation to the ptotic lid, I need to know whether there any
Yeah.
due to
Yeah.
increased innervation, there can be other eye ptosis maybe hidden, sir.
Did you test for it?
Yes, sir.
You have written in the. Did you write it in the case sheet presentation about
Yes,
herrings?
sir. Yes, sir. I wrote it, sir.
You wrote it. Okay, sorry, I missed it. Yes, sorry, I missed it. So, what is your plan?
Sir,
Do you consider it as a mild ptosis, moderate ptosis, or severe ptosis?
sir, I didn't understand the question, sir.
Is it a mild ptosis?
It's a severe ptosis, sir, as there is 4 mm of ptosis.
Right. It's
More
a
than or
severe,
equal to 4 mm is considered severe ptosis.
severe ptosis. Very good. So, how is the LPS action?
Sir, LPS action in this case is poor, sir.
Poor. So, what do you want to do?
As there is poor LPS function, there is no need to resect the LPS. I want to do frontalis sling surgery, sir.
You want to do the frontalis sling surgery. Okay. Does the patient had amblyopia?
No, sir. The vision is 6/9, improving to 6/6, sir, in right
Improved
eye.
to 6/6. Okay, that's great. So you do a unilateral. Which material you prefer to use?
Sir,
Brow
best
suspension.
best one is to use autologous facial later, sir.
Okay.
But we can also use silicone material or any other unabsorbed sutures like 10-proline, ethibond,
Proline and
methylene.
ethibond, they are not great materials.
Okay, sir.
Either autologous fasciolata or probably silicone
Okay,
biopsy. There they give. So what are the various methods of doing the brow suspension? Do you want to do uniocular or unilateral brow suspension or bilateral brow suspension?
In this case, I want to
In
do
this case
unilateral
only.
brow suspension, sir.
Why not bilateral brow suspension?
Bilateral, if there is if Herring's test is positive,
How
I'll
does herrings will cause the bilateral brow suspension? Why herrings for bilateral brow suspension?
sir, because increased innervation.
Right. Suppose there is an increased intervention and there is a mild ptosis in the other eye. You would like to do a bilateral brow in that eye?
Yes, sir, bilateral.
What are the disadvantages of unilateral brow suspension?
After, sir, there might be asymmetry between the two eyes after surgery, sir.
Not there might be. It is there will be.
There will be. Okay, sir.
Asymmetry between the eyes, except in one direction. Because
Yes.
after a brow suspension, the lid moves by about 5 to 8 millimeters only from the down gaze to up gaze.
Yes.
Whereas the normal lid moves by about 15 millimeters.
Okay.
Right. For this reason, there will be a lot of asymmetry. And some people believe in bilateral brow suspension. They don't do unilateral brow suspension for the simple reason that the lid will go up only when the eyebrow is used.
Okay.
Okay. If the eyebrow is not used, the lid will be dropping down.
Okay.
There will not be any change in the lid position. So some people, what they say is that there is no need for the patient to use the normal eye or eyebrow of the normal eye to lift it, because to lift a single brow is difficult. Only 15% will be able to do.
Okay, sir.
About 85% they lift both the eyebrows together. So when there is no visual need for this girl, it's the right eye that is ptotic, right?
Yes, sir.
Left eye is normal.
Yes, sir.
So all these 23 years, she is depending on her left eye only for vision,
Yes, sir.
right? Suppose you lift the lid with a brow suspension, there is no visual need for her to use the right eye because she can see clearly with the left eye.
Yes, sir.
So what they do is they disinsert the LPS from the normal eye and they anchor it to the periosteum.
Okay, sir.
Once you disinsert the LPS from the left eye in this girl, what happens? The LPS action becomes 0.
Yes, sir.
Right. So you do a bilateral brow suspension. Then if the girl doesn't use the brow on the left, both the lids will droop down and cause obstruction to the visual axis.
Yes, sir.
That is why they use both the brows to lift it up.
Okay, sir.
So with this, the results will be better. Both the lids move by only 8 millimeters so that the symmetry is better.
Okay, sir.
This is what is proposed by Kroll Beard, and some of his students do it very, very regularly. They do a bilateral brow suspension. But first thing is you should be convinced to convince the patient and the patient's attendants.
Yes, sir.
And under Arogyasri and these schemes, insurance, bilateral brow is not accepted, then you have to do unilateral. Okay. There is another procedure called Calhan's procedure. In Calhan's procedure, they do not disinsert the levator from the normal eye, but they put a sling so that when the patient is looking down, it causes lid lag so that both the eyelids will match in down gaze, but not in up gaze. That is the Calhan's method, otherwise called chicken hearts method. Okay. So these are the questions that can be asked to you in the examinations that you should be, all the postgraduates should be aware.
Okay, sir.
Okay. So what you can do is you can use a RO sling, silicone. Of course, I have no financial interest. A silicone sling to do a fox pentagon and lift the lid up so that the patient can be comfortable. But the most important complication is lag of thalamus,
Yes, sir.
which can be permanent. Right?
Yes,
So you should be very careful in explaining this to the patient. You have to document that you have explained to the patient. And one good thing with the brow suspension using silicone rod is that you can adjust later the lid height by adjusting the strings which are permanent. You make incision in the forehead where you have buried the sling and adjust the height of it, and again still you can bury it. That is another advantage of using a silicone sling. And you see, I have done both bilateral as well as unilateral. My results are better with bilateral, but Unilateral also fairly good, I'll say. So that if they are not comfortable for a bilateral surgery, you can jolly well go ahead and do a unilateral surgery. At the same time, document saying that under correction is a little more common after unilateral surgery when compared to bilateral surgery. Okay.
Okay, sir.
So it's a case of congenital. Why there is a lid lag and down gaze in congenital ptosis?
Because due to dystrophy of the LPS, both contraction and relaxation will be deficient, sir.
Right.
So on downward gaze also there will be lid lag.
So there will be the fibrous tissue prevents the total relaxation of the levator, and so the lid is held up a little when compared to the normal lid. Right, that's what happens with the fibrosis. And these changes are, the greater the changes, the lesser is the LPS action. So in a LPS with poor function, you expect more of fibrovascular infiltrates, components and infiltrates into the levator palpebrae superioris. Okay. What are there any contraindications for surgery for this liver?
No,
No,
sir.
no. Does she have any lag of thymus? Did you test
No,
for
sir.
it?
Yes, sir.
There's no lag of thymus, right?
And
How do you
Bell's
test for?
phenomenon is good, sir.
Pardon?
And Bell's phenomenon also good, sir.
Bell's phenomenon is good and there's no lag of thymus. How do you test for lag of thymus?
We'll ask the patient to close the eyelids, sir.
To gently close the eyelids, not close the eyelids. They can do it forcefully.
Okay, sir.
Ask the patient to gently close the eyelids as in sleep. That's what you have to tell the patient. నిద్రపోతున్నప్పుడు మూసినట్టుగా నెమ్మదిగా కళ్ళు మూసుకోమ్మా అని చెప్పాలి. ఓకేనా?
Okay, sir.
తెలుగు వస్తుంది కదా?
Yes, sir.
Okay, great. So gently close the eyelids and then you have to look from below, not look straight. You have to look from below.
Okay, sir.
So that small lag of thymus that is there, which can be masked by the curvature of the eyelid, when you look straight on, can be made out. This small opening here can be made out by looking rather than straight. Okay.
Yes,
That
sir.
is very important because if there is a lag of thymus and skirmers is not great, cornea is a little unhealthy, probably you prefer to do a under correction.
Yes, sir.
And inform the patient that if necessary, we may have to undo the surgery. And in that situation, I prefer a sling with silicone rather than with fasciolata.
Facial.
Yeah. What is the latest and more commonly done or more popular surgery that has come recently into vogue for brow suspension?
Modified Crawford technique.
Oh. No,
Don't know, sir.
no. Frontalis flap.
Okay, sir.
Frontalis flap is the latest that has come into vogue for the last couple of years. And I was speaking with I have no personal experience, to be honest with you, since I have almost leading a retired life. I'm not too active. I go only work for only 2 days a week. And I spoke with some of my friends abroad, and most of them have switched over to frontalis flap. And they said that the results are much better than frontalis sling with fasciolata. That's the opinion that I got, that what I'm sharing with you all people. Right? Frontalis flap is the latest trend in brow suspension. Okay.
Yes, sir.
Right. So that's a fairly good presentation from you.
Thank you, sir.
Did well, covered everything under the guidance of ma'am, I suppose. Good.
They're doing regularly.
Good. That's good. That's good. That is
Yeah,
good.
I think that's an
Mm.
excellent presentation, and we had a very nice discussion. And whatever bilateral thing Sir has told, I think Sir has told it already in the last class.
Yeah.
Yeah,
Most of
if you are able to follow that, whatever discussion has happened today, Sir has clearly covered that in the last class that took on Tuesday. Right. Thank you, sir.
So,
Thank
a
you so
small
much.
thing, sir.
Welcome.
Excuse
Thank
me.
you.
Sir,
చెప్పమ్మా మేడం మీరు చెప్పండి.
recently our students are, when they are going for the pediatric, they are getting the referrals, newborn babies with congenital coloboma. So how to you please give the advice what to do.
Tensils
How
అమ్మా.
to
Tensils flaps అమ్మా. Most of the
but
time they
the
can be.
newborn babies, but here immediately can operate, or they have to.
If the cornea is getting compensated, you
Sir.
can use a BCC for 2 or 3 months, and at the about age of 3 months, you do the Tensils procedure. When the anesthesia is much more safer,
3 months minimum.
3 months we can do it. 3-4 months we can do it. For the child, I have shown you, I did it at the age of 3 months. I have done it 3 months. Good evening, Prabhakar Shastri garu. Unmute, Prabhakar Shastri garu. I am not able to hear you.
Unmute చేసుకోండి సార్.
They make things much easier for restaurants by mixing carbonated water with syrup instead of storing convenient drinks. This saves a lot of storage space. However, if the machine isn't properly
సార్ వినబడటం లేదు నాకు. అన్మ్యూట్ చేయండి సార్ ప్రభాకర్ శాస్త్రి గారు.
Yes, sir. I have sent the request also to unmute.
Yeah.
Yeah. Right. And I also thank Meenakshi madam. Thank you, ma'am. Thank you for making your PGs participate in such short notice. They have done an excellent job. Sir, I think the next week presentation is on entropion and ectropion, yes, sir?
అవునండి. Marginal
sir.
mal position and including lag of thalamus.
Yes,
It
sir.
may take a long time. Probably it may, or shall I have to, అంటే కేస్ ప్రెజెంటేషన్ టైం ఉండకపోవచ్చేమో. కేస్ ప్రెజెంటేషన్ పెట్టుకుందాం.
Next time we'll not have it, sir. We'll have it
It's
alternate.
1.5 hours presentation, roughly 1 hour 20 minutes పట్టొచ్చు.
No, next exclusive lecture పెడదాం, sir.
Like, okay.
Right,
Okay,
sir.
okay.
Right, sir.
Right.
Thank you all. Thank you all for
Thank
your.
you. Thank you.
Thank
Right,
you.
sir.
Thank you.
Thank you, sir.
Thanks so much. Thank you.
Thank you very much.
Bye.